Dr. Stadnik.
Okay, good morning, everyone. We're going to start rounds. Just a couple housekeeping issues. This is our last rounds for the academic year. We will be resuming rounds in September, the first Wednesday after the long weekend. So hope everyone enjoys their summer, and we will resume in the fall. So it's my pleasure today to introduce one of our cardiac surgery residents, Dr. Kenza Rahmouni. She's going to be talking today on the role of dual antiplatelets post cardiac surgery. So welcome.
Good morning, everyone, and thank you for the introduction, Dr. Stadnik. So we will start this morning with a brief review of the most recent guidelines on dual antiplatelet therapy for CABG. We will then review some of the evidence to support those guidelines. And we will finish by identifying some of the remaining unknowns regarding the use of DAPT in CABG patients. And we will specifically focus on 2 studies from the Heart Institute. Within our field, CABG is the most commonly performed cardiac surgery procedure worldwide. And in Canada, 51 patients undergo surgical revascularization for every 100,000 patients every year. Here at the Heart Institute, CABG is by far the most common surgery, approaching about 900 cases in the past academic year. Although excellent technical skills and perioperative clinical decision-making are paramount for good outcomes following CABG, postoperative medical therapy is as essential. Medical therapy encompasses the management of hypertension, glycemic control, dyslipidemia, and antithrombotic and antiplatelet therapy. Antiplatelet therapy with aspirin, with or without a P2Y12 inhibitor, is the standard of care nowadays to reduce vein graft occlusion and adverse cardiovascular events. And the rationale for use of antiplatelet therapy is derived from our understanding of mechanisms of graft failure. We know from many clinical trials and experimental studies that vein graft failure is, during the first year after revascularization, is triggered by 2 consecutive mechanisms. A phase of thrombotic occlusion during the first postoperative month, followed by a late phase of intimal hyperplasia. I will now briefly review the guidelines of DAPT in CABG, and there is a lot in the guidelines, so for the sake of brevity, I will not cover the use of DAPT in patients with coronary artery disease treated with any other modality than CABG. To my knowledge, the 3 most recent guidelines that touch upon the topic of DAPT in CABG in North America and Europe are the 2016 ACC AHA focused update, the 2017 European guidelines, and the 2018 update on the use of antiplatelet therapy. So I will spend the next few slides to summarize some of their key recommendations for both ACS and stable coronary artery disease. In the 2016 American guidelines for patients who suffer from an ACS and who undergo CABG, DAPT is recommended for a total of 12 months following the acute coronary syndrome. This is similar to the 2018 guidelines, who also recommend up to 12 months of DAPT in this patient population as a class 1 recommendation. Moving on to stable CAD, in the American guidelines, there is a class 2B recommendation for 12 months of clopidogrel DAPT following CABG in patients with stable ischemic heart disease, and that's to improve vein graft patency. The European guidelines also assign a class 2B recommendation for DAPT after CABG in stable CAD for selected patients. For example, those who undergo coronary endarterectomy and those who undergo off-pump CABG. This figure summarizes what I just said. It's taken from the American guidelines document, and it's about the use of P2Y12 agents in CABG. So in stable ischemic heart disease, there is a class 2B recommendation, as I said, for 12 months of clopidogrel DAPT. In patients with recent ACS, DAPT should be used for 12 months as a class 1 indication. And lastly, for patients with a recent PCI, DAPT should be used as dictated by the PCI therapy, often ranging from 4 weeks, to 12 months. 3 landmark trials were instrumental in guiding the elaboration of the guidelines I just presented, and I will now go over each of them in a bit more detail. We will start with the CURE trial. This randomized control trial included over 12,000 patients with non-ST elevation ACS. Among the exclusion criteria, we find NYHA class 4, recent PCI or CABG within 3 months, and disabling or hemorrhagic stroke. Patients were randomly assigned to clopidogrel and aspirin or to matching placebo and aspirin on a double-blind basis. A total of 12,562 patients were enrolled, of which 2,072 underwent CABG. Of these patients, 1,011 were assigned to clopidogrel DAPT and 1,061 had the placebo treatment. It's very important to remember that randomization occurred at the time of ACS and not at the time of CABG. Overall, 9.3% of patients in the clopidogrel group experienced the primary outcome of cardiovascular death, MI, or stroke, compared to 11.4% in the placebo group. This corresponded to a relative risk of 0.8, which was significant. For the CABG population, though, there was no difference between clopidogrel and placebo, regardless of whether patients underwent the revascularization with an index hospitalization or later. This is a very interesting figure, which shows that most of the benefit of clopidogrel in the CABG population occurred between the time of randomization and CABG. After CABG, there did not seem to be any further benefit of the clopidogrel DAPT. In other words, 23 of the events occurred before CABG, whereas only 6 events occurred after surgery. Overall, the bleeding rates were higher in the clopidogrel group as compared to the placebo group. For the entire study, there was a 1% excess of major bleeding, but no significant life-threatening bleeding. Among the patients who underwent CABG, there was an additional 2.1 and 1.3% of major and life-threatening bleeding, respectively, with clopidogrel, although neither of those was statistically significant. So to summarize the CURE trial, there was a decrease in the composite of cardiovascular death, MI, or stroke with clopidogrel and ASA without a significant increase in bleeding. In the CABG population specifically, the effect of DAPT was primarily due to the events that occurred between randomization and surgery. And after surgery, there was no further benefit. It's very interesting to me that despite these findings, the CURE trial was used as evidence to support the Class 1 recommendation in the American guidelines to support DAPT for 12 months after ACS in patients who undergo CABG. We'll talk about the TRITON-TIMI 38 trial next, which compared prasugrel to clopidogrel in a cohort of over 13,000 patients with moderate to high-risk ACS. In this study, the hazard ratio of the primary efficacy endpoint of cardiovascular death, non-fatal MI, and non-fatal stroke was significantly in favor of prasugrel over clopidogrel. However, again, as expected, prasugrel was associated with significantly higher rates of major bleeding, including life-threatening bleeding. A sub-study of the CABG cohort in the TRITON-TIMI 38 trial was subsequently published. This was a risk-adjusted retrospective analysis of the 346 patients who underwent CABG within the trial and who received at least one dose of the study drug prior to CABG. Again, the patients were not randomized at that stage. They were randomized at ACS presentation. But to make up for that, baseline characteristics and imbalances were corrected for using the Euroscore and the STS risk scores. The primary outcome of this retrospective risk-adjusted analysis was chest tube output within the first 12 hours following surgery. There was a significantly higher overall mean chest tube blood loss at 12 hours in the prasugrel group compared to the clopidogrel group. And there was a trend towards higher incidence of surgical reexploration for bleeding, but it was not quite statistically significant. When looking at the cumulative incidence of all-cause death across time from isolated CABG, there was a statistically significant lower risk of mortality in the prasugrel group compared to the clopidogrel group before and after risk adjustment with the Euroscore mortality risk. So to summarize, despite an increase in observed bleeding, platelet transfusion, and surgical reexploration for bleeding, patients who had prasugrel before isolated CABG were observed to have a mortality rate that was significantly lower than patients administered Plavix or clopidogrel before CABG. The lower mortality rate in prasugrel was even consistent after risk adjustment with the Euroscore and STS score. But as I mentioned, there are a lot of limitations with this study, including that it's a retrospective post hoc analysis. And there were possible unknown confounders because of the time of randomization and the relatively small group size. The third study is the PLATO trial, which compared ticagrelor to clopidogrel in patients with ACS. In this trial, treatment with ticagrelor as compared with clopidogrel was led to a significantly reduced rate of death from vascular causes, myocardial infarction or stroke, without an increase in overall rate of major bleeding, but with an increased rate in non-procedure related bleeding. A sub-study of PLATO looking specifically at the CABG population was later published 2 years after the original trial. PLATO was an international prospective double-blind, double-dummy RCT enrolling patients with ACS, both STEMI and non-STEMIs. Among the 18,624 patients enrolled in PLATO, 1,261 underwent CABG and were receiving either ticagrelor or clopidogrel within 7 days of the surgery. The occurrence of the primary endpoint, which was defined as composite of cardiovascular death, MI, or stroke, with ticagrelor compared to clopidogrel from the time of CABG onward, was 10.6% versus 13.1%. And this was consistent with the results of the whole trial. In the CABG population, this was driven mostly by the reduction in cardiovascular death from 7.9% in the clopidogrel group compared to 4.1% in the ticagrelor group. But it's unclear to us whether the difference in cardiovascular death was mostly before or after revascularization, because again, patients were not re-randomized after CABG. With regards to bleeding following CABG in the Plato cohort, there were no significant differences between the ticagrelor and clopidogrel groups. Major CABG-related bleeds, defined as bleeding associated with a hemoglobin drop of 30 to 50, and bleeding requiring transfusion of between 2 and 3 units of red blood cells, that occurred in 81.2% versus 80.1% in the ticagrelor and clopidogrel groups, respectively. So no major difference there. And nearly all bleeding events occurred within 24 hours after CABG. In this figure, you will notice that there is a mortality benefit from 2 to 4 days after discontinuation of the antiplatelet agent, which is gone by 5 days. And this is supporting the concept that there may be a latent antiplatelet effect present at time of CABG, even though we discontinued the antiplatelet agent a few days earlier. So to summarize Plato, ticagrelor was associated with a significant reduction in cardiovascular mortality at 1 year compared to clopidogrel in both the entire ACS population and the CABG subpopulation. This was achieved with no significant difference in bleeding events. And again, one major limitation of these results is that they are retrospective in a non-randomized group. So this, what I just presented, is mostly exploratory information. I decided to include a few slides on off-pump surgery, even though it's a relatively small proportion of worldwide CABG. But the reason I did is because in Ottawa, we have a very high volume. In fact, one of the highest in the country. So I will discuss the CRISA trial, which is a single-center prospective RCT evaluating the impact of DAPT with ASA and clopidogrel in patients who underwent off-pump CABG. The trial consisted of 300 consecutive patients who had isolated off-pump CABG for stable coronary artery disease, and these patients had to have at least one saphenous vein graft. Patients were randomized 1-to-1 to receive either aspirin alone or aspirin and clopidogrel postoperatively. And they were randomized once the chest tube output was less than 50 cc's an hour for 2 consecutive hours. Study outcomes were divided into 3 categories. First of all, the antiplatelet response, 12 months graft patency, which was assessed on CT angiography, and clinical outcomes, which consisted of bleeding. They used the same definition as the CURE trial, and presence of major cardiac and cerebrovascular events. There was overall no difference in clinical outcomes between groups, both for bleeding and MACE. With regards to angiographic results, there were significantly more occluded grafts in the ASA alone group compared to the dual antiplatelet therapy group. And this was driven by the higher incidence of saphenous vein graft occlusion in the ASA alone group, but there was no difference in the LIMA, RIMA, or radial artery grafts. So to summarize, CRISA showed that DAPT improved saphenous vein graft patency and off-pump CABG, and it did not increase bleeding complications compared to aspirin alone. The last study I will present today is looking at ticagrelor DAPT in patients with CABG. It's conducted by Sender and colleagues who did a individual patient data meta-analysis comparing the risk of vein graft failure and bleeding associated with ticagrelor, DAPT, ticagrelor monotherapy, or aspirin alone among patients undergoing CABG. The primary outcome was the incidence of saphenous vein graft failure in randomized controlled trials comparing ticagrelor DAPT with aspirin. Saphenous vein graft patency in this study was assessed either using invasive angiography or CT angiography, depending on individual RCT defined follow-up time. Failure in this study was defined as a stenosis of 50% or more. A total of 4 RCTs were included in the meta-analysis involving 1,316 patients and 1,668 saphenous vein graft. The 4 RCTs were TAP CABG, DACAP, Target, and Popular CABG. With regards to the primary outcome of this IPDMA, ticagrelor DAPT was associated with a significantly lower incidence of saphenous vein graft failure compared to aspirin, with an incidence of 11.2 versus 20% respectively. This finding was also present and significant when assessing the incidence of graft failure per patient. As well, this finding was significant across most subgroups, including diabetes, smoking, ACS, off-pump surgery, and sequential vein grafting. Interestingly, there was no difference between ticagrelor and aspirin in women, but this is likely because it was a very small number of women, so it may not have been a high power, and we can see that with the large confidence interval. So like in previous studies, ticagrelor DAPT was associated with significantly higher incidence of actionable, severe, and fatal bleeding events, which were in this study defined using the Bleeding Academic Research Consortium criteria. With regards to cardiovascular events, ticagrelor DAPT was associated with a significant reduction of composite of vein graft failure and cardiovascular death. So to summarize the findings of this IPDMA, in patients undergoing CABG, adding ticagrelor to aspirin was associated with a decreased risk of vein graft failure, but this was at the cost of clinically important bleeding. So despite the very, very, very large body of data on DAPT for coronary artery disease, we have many questions remaining. For example, what is the impact of antiplatelet agents on arterial conduit patency? What is the role and optimal duration of DAPT in stable CAD post-CABG? What are our patient perspectives as it relates to DAPT after surgery? And how do patients and perioperative characteristics influence the efficacy and risks of DAPT after CABG? I will now present 2 studies designed at our institution to address some of these unknowns. The first study is entitled Defining the Role of DAPT After CABG. This will be a large population-based study which will permit the identification of specific patient cohorts who benefit or who are harmed from treatment with DAPT after CABG. This knowledge will hopefully enable a personalized approach to DAPT It will hopefully also improve patient engagement and education, and it will enable power calculations for design of a subsequent RCT, which is the ultimate ultimate goal of our research team. We will perform database linkage of ICIS, Core Health, and the Ontario drug benefit data for patients who underwent CABG in Ontario. We will include all patients aged 65 years or more who underwent isolated CABG after October 2008. And the reason for the age cutoff of 65 is because the Ontario drug benefit database only includes patients 65 years or older. In this study, we will look both at ACS patients and stable coronary artery disease patients together and separately. Our primary outcome will be 1-year MACE. Secondary outcomes will include all-cause mortality, composite of MACE, and major and actionable bleeding. We will assess the impact of multiple variables on our primary and secondary outcomes, including P2Y12 adherence and social determinants of health. We will also evaluate hypothesis-driven patient and operative covariates, including sex and off-pump surgery. This is a very interesting part of the study, in which we will be holding patient consensus conferences to engage patients who underwent CABG and their family. The goal of these consensus conferences is to better understand patient beliefs, value, and factors that may influence their compliance with DAPT after CABG. To achieve our goal, we will use discrete choice experiments to develop and seek consensus on recommendations for DAPT that patients themselves can identify based on their own values, considering risk versus benefit of DAPT. These conferences will be led by a clinical care facilitator, such as a cardiology resident and a cardiac surgery resident. We anticipate that this large population-based study will help us better understand the current trends in prescription of P2Y12 inhibitors after CABG in Ontario. It will help us also better understand patient procedural characteristics that may influence outcomes in patients treated with DAPT after CABG. And lastly, we will hopefully have a better understanding of patient perspectives and how they influence compliance of P2Y12 inhibitors after CABG. The second study I will present is the ODIN trial. There are many studies that found that decreasing DAPT duration does not compromise cardiovascular outcomes while decreasing significant bleeding. The ODIN trial is taking this concept from the PCI world and is applying it to coronary surgery. So the rationale of the ODIN trial is therefore to balance, on one hand, the risk of bleeding with, on the other hand, the risk of graft occlusion. And this will be hopefully done by limiting the duration of DAPT to the early post-surgical bleeding when the healing of vascular and endothelial damage takes place. The main hypothesis is that 1 month of ticagrelor or DAPT will optimally balance the efficacy and safety of DAPT after CABG based on the differences in timing of bleeding and ischemic risk. The ODIN trial is a prospective, unblinded, open-label international RCT with 45 participating centers. Patients will be randomized 1-to-1 between ticagrelor DAPT for 1 month, followed by aspirin or aspirin for 12 months. Randomization will occur within the first 48 hours of CABG once the risk of surgical bleeding will be deemed minimal. The two primary outcomes of this trial will focus on the effect of 1 month ticagrelor DAPT with regards to ischemic outcomes and major bleeding events. The trial has been funded by CIHR and is planned to start enrolling shortly. To conclude, there is a very large body of data on DAPT post-CABG. Today, we reviewed a few of these studies, including CURE, PLATO, TRITON, and CRISA. In all these studies, bleeding was a major concern with DAPT, especially after surgery. We have many remaining questions with regards to DAPT in CABG, and I presented two studies from the Heart Institute today that will hopefully help and bridge some of these gaps. And this will hopefully achieve our common goal of providing patient-centered medicine and decision-making for patients who have CABG and will receive DAPT therapy. Thank you everyone for your attention, and special thank you to the people mentioned on the slide for their support.
Thank you, Kenza. There's a question, a couple questions in the chat, actually. So one from Dr. Lam. Excellent presentation, Kenza. Could you please expand on the ESC's recommendation of DAPT in off-pump CABG, particularly rather than on all CABG patients? And is off-pump CABG a greater prothrombotic risk factor?
Thank you, Dr. Lam, for the two questions. The ESC guideline is supported by the CRISA trial that I presented and some cohort studies of non-randomized trial, which with smaller patient sizes. I elected not to present them for time's sake, but those are the sources of the Class 2B recommendation. And for the second question regarding whether off-pump CABG provides a greater prothrombotic risk than on-pump CABG, it's a very interesting topic. And I think that there might be a technical challenge with a moving target literally while doing the anastomosis, which may cause more endothelial trauma at the time of surgery, and therefore could be the argument for a higher prothrombotic risk after off-pump CABG. But I believe that just like any cardiac surgery procedure, the higher the volume of the surgeon, the better the outcomes. And that applies to off-pump surgery as well.
Next question from Dr. Chung. A great overview of the current data. How robust is the evidence using 325 milligrams of aspirin versus 81 milligrams?
Thank you, Dr. Chung. Again, I did not mention the aspirin alone studies, which are even older than the three trials I reviewed, but from my knowledge, they're mostly based on cohort studies, which I don't have slides for here, but maybe someone in the room could comment if they have more knowledge. I see Dr. Rubens here.
Thanks, Kenza. First of all, fantastic presentation. You covered this wealth of data in very succinct and manner with excellent slides. The aspirin data that we work with, you're absolutely right. It is derived primarily from poorly designed cohort studies from the 80s and 90s, and then nobody's reopened the door to see if it's even necessary. As I've mentioned to you before, the earliest studies on aspirin in coronary surgery, if you look very deeply into the trials from Lancet and everything else, there's zero benefit for aspirin in saphenous vein grafts in LAD greater than 2 millimeters in diameter, a big target. There's zero evidence that aspirin is beneficial with arterial grafts. There's poor data that supports either aspirin 80 milligrams or 325 milligrams. It's poorly designed trials, not nearly the quality of trials that you have quoted today. So is there evidence as to when we should switch? Who knows? And I don't think we're in an environment where people would agree to stop aspirin altogether, particularly in the presence of vein grafts. I'd be interested in Derek's comments.
Yeah, so I think conceptually, as per your comments, a lot of this is based on vein graft patency, right? And it's interesting, even on the ACS side, people are hesitant in terms of stopping that aspirin too early, especially in that ACS population. But there is a European trial right now that they're actually going to stop it at time 0. So a P2I12 alone versus DAPT in ACS patients. So I guess fundamentally on our side, that paradigm is shifting. And one of the things I was going to ask you specifically was a lot of the trials you show, even let's say looking at that Plato or the TRITON sub-studies, their primary endpoints has really been fixated on bleeding. And then a lot of the DAPT trials looking at general bypass patients have been looking at vein graft patency. But one of the things that we've seen both from TRITON and from Plato is that mortality signal comes out. And as you know, we had a meta-analysis specifically looking at a more potent platelet anti-strategy versus less potent, and consistently, irrespective whether it's a P2I12 or 2B3A, that when you look at the randomized studies, that there is this mortality signal. Do you think on the surgery side that sort of concept of endpoints need to shift nowadays, that rather than being fixated on bleeding or vein graft patency alone, is that we actually have to look at hard outcomes, longer outcomes, because this mortality signal has always been there. It's just that it's very difficult to power your studies to enable actually to prove this. So I just love your thoughts on this, Kenza, and also Fraser and others in terms of how we can change that paradigm. And again, a great review. Those slides were excellent, and it's a very hard topic to cover everything.
Thank you, Doctor. So maybe I can start and then Dr. Rubens can complement. But we know that the most important graft in CABG is unequivocally the Lima to LAD graft, which is not obviously a vein. So I agree that even though there may be data to point a lower saphenous vein graft patency, the mortality outcomes may not differ in the long term. And that's a very big challenge to assess in surgical populations because, as you alluded to, Dr. So, we would need extremely large cohorts. Plato, TRITON, and CURE were several thousands of patients, 18,000, 13,000. So I think a good way to reconcile this and to really understand whether vein graft patency and mortality are inherently linked to each other would be to conduct a very large scale surgical RCT. And I'm not aware of any ongoing at the moment. And maybe that's because, as Dr. Rubin said, our practice nowadays is based on studies from the 80s, 90s that we don't really question anymore. Even the Lima to LAD graft has been proven in 1980 by Loop and colleagues. So I think, yes, the best way would be a very, very large RCT, multi-center international.
Lots of questions. I see we've got a couple hands up, but there's one chat question that came in first. So Dr. Laflamme, great talk. What consideration, if any, has been given to clopidogrel non-responders or any platelet reactivity testing in these trials?
That's a very good question. And there have been studies looking specifically at platelet response in one of their outcomes. I didn't go into details for that, but the CRISA trial, the one looking at off-pump CABG, did study platelet response. They did that with assays of platelet aggregation and inhibition and platelet functional testing as well. And in CRISA specifically, they found that the benefit of antiplatelet therapy, whether being aspirin or clopidogrel, was only present, of course, in antiplatelet respondents. So that raises another question. Should we eventually in the future perform antiplatelet response assays for each of our patients in the hope of providing patient-centered care? Is this cost effective? Is this too much work? So that's a very good point to raise.
And I think along that lines, and also in conjunction with what Dr. So said, Dr. Labrinez makes the comment that, you know, there is accumulating evidence that aspirin discontinued in just a P2Y12 inhibitor is a strategy that is perhaps being adopted and studied. Are there any trials that you know of that are being designed in the CABG world to look at just monotherapy?
I personally am not aware of any.
Yeah, it doesn't look like anyone in the audience so knows of any other. Dr. Russo, did you have a comment?
Yeah, no, I just wanted to add that I do find that the sub-study of Plato that's listed in the meta-analysis by Health that basically look at the whether essentially ticagrelor was superior to clopidogrel in patients undergoing CABG after ACS. Like there was a strong signal, and I just wanted to hear, in the absence of any additional evidence, which I guess might take some time to accrue, whether in this environment people were weighing for or against antiplatelet, because I do find that analysis pretty telling. The fact that a more potent antiplatelet would result in a reduction in cardiovascular events in the post-surgical setting. Again, in those patients in Plato that are underwent bypass. Maybe Dr. So or Dr. Rubens can weigh in.
Just a quick comment before Dr. So takes the mic. Yes, definitely we see that more potent antiplatelets do have tend to have a mortality benefit, and this is one of the reasons why ticagrelor was chosen in the ODIN trial as opposed to clopidogrel. It's because of that. It's been shown that ticagrelor is better than Plavix for CABG patients. So yes.
So I absolutely agree with you. Conceptually, that's what the data shows, and this is a meta-analysis on the screen there. But one of the things we have to remember is that be it Plato, be it TRITON, patients weren't, or even CURE, patients were never re-randomized after surgery. And so one of the things that we don't know is that potency of agent benefiting at upfront, especially in ACS patients before they get to bypass surgery, or is it afterwards? The other thing about ticagrelor is it's not just the patency when it comes to surgery, right? It's that it also that offset component of ticagrelor. That remember at 2 to 5 days, that platelet inhibition in someone on ticagrelor is equal to someone that's on full dose clopidogrel, and by 5 days it wears off. So potentially you've got benefits of both ends, that if you're going early to surgery, you've got some platelet protection that's equal to clopidogrel, but it wears off in that post-operative period where you're concerned about bleeding. And then at that point, restarting it, do you then again reconfer that platelet benefit? So I think there are lots of unanswered questions on that true post-operative phase if you re-randomize patients. And the one thing with ODIN is that keeping in mind that ODIN population is going to be stable coronary disease. And all ACS guidelines right now still consistently would suggest a long-term 12-month of dual antiplatelet therapy. So ODIN is going to fill in that gap in terms of that stable CAD patients. But I think on the ACS side, there still needs to be data in terms of both choice of agents, duration of agents. And I think those are things that somehow needs to be addressed, but it's just going to be difficult to address.
I just,
agree. And I do remember that the Kaplan-Meier curves, Derek, do seem to diverge over time. So I wonder if, if that is actually benefit that's accrued immediately when you present before bypass, or maybe a benefit that continues to accrue as you go on. Because I think most of these patients were continued on the 2Y12 receptor antagonist after CABG as part of the protocol.
I wanted just to reiterate the interesting thing that Derek and I have been working on, which is to really integrate the patient's perceptions with regards to these drugs and how that really needs to be an outcome that we have to consider, as opposed to these perhaps minuscule, in some cases, benefits in survival. When we have our revasc rounds, as many of you know, often a comment will come up, this patient doesn't want to be on dual antiplatelet therapy, but then we're referring them to surgery and they're on dual antiplatelet therapy so we're really defeating the purpose. I just bring to your attention a recent patient that was sent to me, a homeless man, and I did all arterial grafts. It's gone from hospital, no aspirin, no ticagrelor, no clopidogrel. He'll take nothing, and he did wonderfully. And I think we need to look at the options. We have other surgical strategies to maybe integrate in this. We hope to find out more information with regards to all arterial grafting in terms of the outcomes in patients when they do have these different antiplatelet drugs. So I think it's going to be an exciting way of defining the types of surgery that we do and integrating the patient's perceptions into those desires when we strategize on that operation.
Kenza, there's a question from Dr. Beanlands. In patients who develop atrial fibrillation and require a DOAC, is it reasonable to stop the aspirin or antiplatelet? And if so, at what timing point post-CABG should this be considered?
Thank you, Dr. Beanlands, for the question. In that specific scenario, from what I've seen is we follow the anticoagulation guidelines first and foremost for atrial fibrillation, and in terms of timing, it depends on each patient, but mostly when surgical bleeding risk is deemed minimal. A specific example is if patients have temporary pacing wires hooked to the myocardium directly, we usually don't start an anticoagulant until the wires are removed. That's the timing we used. And with regards to the choice of the concomitant antiplatelet agent, most of the time we've been using aspirin, except if a patient has a recent stent, in which case we would prefer clopidogrel. Yes. I don't know if that answers your question, Dr. Beanlands, but.
Yeah, that's a very challenging clinical topic, Kenza, and you've handled it quite grandly. This is a challenge that not even the surgeons, the faculty surgeons have an answer to, because oftentimes when I know a specific cardiologist, I'll discuss with them, what would you prefer, aspirin versus Plavix, because we're going to put them on DOAC for a short period of time. The mechanism for postoperative atrial fibrillation is completely different than the usual paroxysmal atrial fibrillation. It's usually related to inflammation. So we don't have data to indicate the length of time the patient should be anticoagulated. Generally, I stop the anticoagulants when they come back to see me at 4 to 6 weeks, but this is being investigated with randomized control trials that are ongoing now, particularly out of Hamilton.
That's excellent. Are there any other questions or comments either in the chat or in the audience? Okay, Kenza, that was really fantastic. Thank you. That was a difficult topic and summarized really lovely. Thanks everyone for attending today. Please rejoin us in September, first Wednesday after the September long weekend. Have a good summer. It's always good.